This presentation is about malaria, and as the slide indicates, it's been killing people for centuries, and it's really impossible to try to guess the number of billions of people it has killed throughout history. It is estimated that it has killed more than any other disease known to mankind. In this presentation, we will learn just exactly what is malaria, its causes, symptoms, life cycle diagnosis, treatment, prevention, history, and most importantly, the prognosis in the future of this number one killer disease. Malaria is a life-threatening disease spread to humans by some types of mosquitoes and is mostly found in tropical countries now, but historically had been found in over half of the world. It is preventable, it is curable, although it is spread by an Anopheles mosquito. It is actually caused by unicellular organisms known as Plasmodium, which is a protozoa, and the infection caused by this parasite is not spread from person to person. Therefore, the mosquito is just a vector or means of transmission from person to person. This slide shows the taxonomy of malaria, Plasmodium protozoa. The phylum of Apicomplexa shows that this type of organism is parasitic. The four species are Falciparum, Valeriae, Ovale, and Vivax. The most early symptoms of malaria are fevers, headaches, and chills. Symptoms usually start within 10 to 15 days of being bitten by an infected Anopheles mosquito. Then intermittent or cycling fevers are classical symptoms of malaria. These fevers are characterized by the synchronous development and subsequent release of the malaria parasites, the protozoans, into the blood. The fevers usually last 6 to 10 hours. These fevers are caused by the lysis or destruction of the red blood cells, but attack usually starts with shivering, chills, followed by a high fever, followed by sweating, and then, very importantly, returning to normal. This is the classic symptom of malaria infection: high fevers, very sickly, followed by feeling absolutely well, and then the repeat of the same. The life cycle is fairly complex and involves two hosts, a human and the infected Anopheles mosquito. After feeding on an infected person's blood, the mosquito receives malarial gametes. These gametes unite to form a zygote, and they produce sporocytes. The sporocytes then migrate to the mosquito's salivary glands, and they can infect another human during another blood meal. The human host, during a mosquito's bite, these sporocytes are injected into the human skin and enter the bloodstream and eventually reach the liver. In the liver, sporocytes then infect blood cells. This next slide, slide 7, just shows another depiction of this complex life cycle. Symptoms dictate a malaria diagnosis test. Malaria is diagnosed by detecting malarial parasites in the blood using a microscope. This is called a blood smear microscopy test. It involves taking a small blood sample from the patient, sending it to the lab to be stained and examined under the microscope. The test can provide results in a few hours and can determine the type of species of malaria and the percentage of red blood cells infected. A negative test is usually followed by 2 more subsequent tests taken 12 hours apart. And this is referred to as the gold standard for laboratory confirmation. Another is a rapid test in which is a very quick way of establishing the diagnosis of malaria. As you can see from the slide, there are 4 different types of malaria, each with a different blood smear stain and a different diagnosis. Each has different yet similar type of drug treatment. Plasmodium falciparum is the most prevalent and responsible for most cases and is found usually in sub-Saharan Africa. Patients with severe falciparum malaria may develop liver and kidney failure, convulsions, and coma. Plasmodium vivax is prevalent in Southeast Asia and in Latin America and is more severe for children. Plasmodium malariae and Plasmodium ovale, less prevalent and less severe, but the parasites can remain dormant in the liver for many months, causing a reappearance of symptoms months or even years later. Plasmodium knowlesi is found in other primates. Prevention chemicals. Listed on this slide are 5 of the most common chemicals to prevent malaria. It's best to start treatment 2 to 4 weeks before travel. Atovaquone has shown this drug to be a good 96 to 100% effective, and it's considered to have few side effects. Doxycycline, 94% effective, but there are more side effects. Mefloquine, taken once a week, is easier than a daily treatment. Chloroquine is safe for pregnant women, and hydroxychloroquine, which is an anti-arthritis medicine, is very effective. As far as ways of preventing malaria non-chemically, bed nets, sleeping under them was one of the most effective ways to prevent malaria. It acts as a physical barrier between individuals and mosquitoes, resulting in the likelihood of not getting bitten while sleeping. Indoor residual spraying involves spraying insecticides in the interior of the house. Wearing protective clothing, long sleeve clothing, pants, socks, can help minimize skin exposure. Now, eliminating mosquito breeding sites by eliminating standing water around your living area can reduce the malaria mosquito population.
Okay, go. Was I moving it back and forth?
Long-term prevention has 4 aspects to consider. The cost. Individually, being purchased is not too much, but purchasing and delivering drugs to a whole population is so much more costly. Sustainability is always a challenge for any long-term preventative programs. Acceptability deals with side effects and can prevent long-term usage. Drug resistance is real important. It can be an issue in the long term. Hopefully, development of new, well-tolerated anti-malarias, which provide long-lasting period of protection, months. Vaccines can reduce the risk of contracting malaria by about 40% and severe malaria by about 30% and deaths by 15%, but the efficacy reduces over a shorter period of time. Malaria is treatable and curable, although it is estimated that 600,000 people die every year from it. Those issues are usually surrounding poverty. The primary objective of treatment is to ensure the rapid and complete elimination of the protozoans in your blood causing the infection. Malaria is treated with prescription drugs to kill the parasite. The types of drugs and length of treatment will vary depending on which type of malaria parasite you have, the severity of your symptoms, and age. The World Health Organization recommends Rotamicinin-based combination therapies, ACT therapies, and it's a combination of two or more drugs that work against the malaria parasite in different ways. You can see the drugs and the chemicals listed on this slide. The combination should be given for 7 days. This slide shows the number of malaria cases from 1990 to 2017. Please note that the y-axis is a logarithmic scale. The number of cases has not substantially changed during this 27-year period. When it shows that Africa has the largest number of cases, it is usually sub-Saharan Africa. Notice that the number of cases in Europe has substantially changed due to the aggressive prevention of cases and eradication of the Plasmodium, protozoan, and the Anopheles mosquito. While this graph does not seem to be positive progress towards eradication, these are just total cases. Remember, malaria is easily preventable and easily curable if treatment is started soon after infection. This slide shows the number of malaria deaths from 1990 to 2017. Again, please note that the y-axis is a logarithmic scale. Again, please note that since 2019, deaths have been drastically reduced. This shows a tremendous reduction of deaths. Compare this chart to the previous chart of total malaria cases. WHO, World Health Organization, is largely responsible for this progress. This chart shows the number of deaths in every world region between the years 2000 and 2020. Most notable are the reduction in deaths in the African region, and it's really the tropical sub-Saharan region where most of the cases occur, and subsequently most of the reduction in deaths occur. In fact, when you take out the African section of this chart, it is notable that the number of deaths in other regions have been greatly reduced. This chart shows tremendous progress. This is the most important slide in this presentation. It contains so much information and clearly shows the incredible progress of the eradication process of malaria. Look at the gray areas. You can see where malaria was not present until the year 1900. Pre-1900, malaria was found in Canada, all over the eastern United States, Scandinavia, and even parts of Siberia. In just 65 years, malaria was eliminated from virtually all of Europe, Central Asia, the entire continental United States. Fast forward to the year 2002, and we find the elimination of malaria in northern Africa, all of Australia, many parts of South America, and many parts of the Middle Eastern world. When you consider that over 50% of the world dealt with malaria before 1900, this shows the greatest success story in the partial eradication of malaria. However, the parts of the world still susceptible to malaria are the Amazon rainforest, sub-Saharan Africa, India, and Southeast Asia. Sickle cell anemia, SCA, is a serious, incurable congenital blood disorder that affects red blood cells. It's caused by abnormal hemoglobin, which causes the cells to become rigid and sickle-shaped. These sickle cells can often get stuck in small blood vessels and block blood flow. This can lead to serious health problems, including heart attack, kidney failure, and death. However, scientists have found a connection between sickle cell anemia and malaria. If a person has SCA or even is a carrier for sickle cell, they are mostly immune to malaria. We find an abnormally high incidence of carriers for sickle cell anemia in endemic malaria regions. As this Punnett square shows, when two carriers for sickle cell disease have offspring, approximately 1/4 or 25% will actually have sickle cell and could easily die. 1/4 or 25% will not be immune to malaria and could easily die from malaria. However, 1/2 or 50% of the offspring will be carriers for sickle cell anemia and live a productive life free from malaria and sickle cell. Malaria has been around for as long as humans have existed and has accompanied almost every episode of human history worldwide. The first written records of the disease can be found in Chinese documents as early as 2700 BC. In 2000 BC, malaria is recorded in Mesopotamian clay tablets. In 1570 BC, it is found on Egyptian papyrus. In 800 BC, an ancient Indian writings called it the king of diseases. Malaria is mentioned in Homer's Iliad in 850 BC, and Hippocrates, Aristotle, and Plato wrote about it in 400 BC. Malaria is a contributing factor in the death of Alexander the Great. About 200 years later, the Romans presumably brought the pathogen from Egypt, and it carried it as far as England and Denmark. Malaria was a permanent feature of early European and American settlements. Around 1900, the malaria pathogen had its largest distribution worldwide and was found in all temperate and tropical regions of all continents. About the time microscopes were getting better in the late 1800s, William Welsh in 1897 identified the protozoan which caused malaria. He named it Plasmodium. And finally, quinine is an alkaloid extracted from the bark of the cinchona tree. It is native to South America, and the tree's curative properties were brought back to Europe around 1640 and was quickly adopted and became worldwide and accepted as the remedy and prevention for malaria in 1681. It's still used to this day. Slides 21, 22, and 23 are references and citations.